Bismillahirrahmanirrahim. Welcome everyone. This is Dr. Waqas from the pathology department. Today we will talk about the restrictive pulmonary diseases. Let's look at the learning objectives. In this lecture, we will talk about what are the restrictive lung diseases. We will have knowledge about different types of restrictive lung diseases, pneumoconiosis, and the pathogenesis of its following types and the clinical features. And this will include three diseases which are co-workers pneumoconiosis, silicosis, and the third one is asbestos-related diseases. We will also talk about the pathology and clinical features of sarcoidosis, which is also involved in the restrictive lung diseases. So, what are restrictive lung diseases? These are also known as the diffuse interstitial diseases. It is a group of disorders characterized by diffuse and chronic involvement of the pulmonary connective tissue. In this group, the pulmonary function tests are characterized as follows. The total lung capacity will be decreased. The forced expiratory volume 1 and forced vital capacity ratio will be increased greater than 80%. Forced vital capacity is decreased and peak flow is also decreased. So one thing you have to consider is that forced expiratory volume 1 ratio with forced vital capacity is the only thing which is increased in the pulmonary function test, and these are the tests which will be consistent with all the restrictive lung diseases. Let's look at the classification of restrictive lung diseases. These involve pneumoconiosis, also known as occupational lung diseases, idiopathic pulmonary fibrosis, which have already been taught to you by Dr. Sadia. Number third one is sarcoidosis and hypersensitivity pneumonitis, which is also involved in the restrictive lung diseases. Let's talk about the first group of restrictive lung disease, which is the pneumoconiosis. It is also known as the occupational lung disease and the dust disease. It occurs due to the inhalation of dust and chemical fumes, which can be organic or inorganic particles over a long period in different occupations. Uh, it refers to a non-neoplastic lung reaction to the organic or inorganic particulates. It depends on the following factors: amount of dust retained in the lungs over a period of time, the solubility and physical reactivity of the particles or the dust fumes which the person inhales, the additional effects of other irritants, for example, concomitant smoking increases the risk of these pneumoconiosis or occupational diseases, the size and shape of the particles, especially the particles ranging from 1 to 5 micrometer in diameter. Let's look at an example of inorganic dusts. These include coal dust, which causes simple coal workers pneumoconiosis or progressive massive fibrosis, and also causes Kaplan syndrome. Silica, which causes silicosis, and it also causes Kaplan syndrome, which I will talk about in detail later. Asbestosis, asbestos, which causes asbestosis, pleural disease, and different pleural tumors, especially the mesothelioma and bronchogenic carcinoma. Beryllium, which causes berylliosis, and iron oxide, which causes pulmonary cirrhosis. So these are some examples of the biological or the organic dust, which include moldy hay causing farmer's lung, bagasse causes bagasosis, cotton, flax, hemp dust, bisonosis. One thing about the bagasse, it is a remnant of sugar cane after the extraction of its juice. It is used as a biofuel. Bird droppings causes bird breeders disease, mushroom compost dust causing mushroom workers lung, moldy barley malt dust causes malt workers lung, moldy maple bark causes maple bark, and silage fermentation which causes xylophyllus disease. Let's look at the normal physiological response of the respiratory tract to different particles in the environment. In the nose, the hair at the external nares filter out the larger particles, trapping almost all the particles larger than 5 micrometer. So only the particles which are less than 5 micrometer will reach the trachea and the bronchi. So in the trachea and the bronchi, 90% of the particles larger than 3 to 5 meter are caught. The remaining one reach the alveolar ducts and the alveoli, and these are the particles which causes the inflammation reaction, and over the period of time it causes massive fibrosis throughout the lung. So let's look at the first factor, which is the size of the dust. So particles larger than 5 micrometer, they reach the terminal airway, and these are ingested by the alveolar macrophages. So these are less dangerous than the smaller particles. Particles which are smaller than 1 micrometer, as I have told you before, are the most dangerous ones. They reach the alveoli and they stimulate the macrophages, causing an inflammatory response leading to fibrosis over a long period. Solubility and cytotoxicity. So smaller particles causes pulmonary fluid and pleural effusion. They achieve rapid toxic levels and also cause acute lung injury. Basically, their small size helps them reach the terminal small airways and air sacs and settle in their linings. and they causes acute lung injury. Larger particles they resist dissolution, persist in the lung over long years, and they evoke fibrosis, silicosis, for example, silicosis for over a long period of time. Physiochemical reactivity, quartz particles. Quartz is basically another name for silicon dioxide, which causes silicosis. They causes direct injury to the tissue and cell membrane, and also trigger pro-inflammatory, pro-fibrosing reaction, ultimately leading to the fibrosis. The systemic response. From the alveoli, these particles reach the lymph nodes with the help of the macrophages, and there they initiate the immune response or a local reaction, and then from there they translocate to the blood, and when they translocate to the blood, they evolve systemic wise inflammation, having symptoms throughout the body and different organs of the body. So that is all about the factors determining the disease of pneumoconiosis. So let's start with an important example of pneumoconiosis, which is coal workers pneumoconiosis. It is caused by the inhalation of coal dust, and obviously it will be commonly seen in coal miners. It is divided into the three types. The first one is pulmonary anthracosis, simple coal workers pneumoconiosis, and the complicated coal workers pneumoconiosis, which is also known as progressive massive fibrosis or PMF. Looking at the clinical features, as I have told you before, these are asymptomatic in the early stages and the person does not develop any kind of symptom. It only occurs when the patient has been exposed for many years in his occupation. So the usual symptoms are chronic cough, especially at night, dyspnea or the difficulty in breathing, chest tightness, often black sputum which occurs in the late stage and the progressive massive fibrosis, and pulmonary hypertension and cold pulmonale, which are the ultimate complication. Cold pulmonale is also known as right-sided heart failure, increased risk for carcinoma of the stomach, but the bronchogenic carcinoma is rare in cold workers pneumoconiosis. Bronchogenic carcinoma is most commonly seen in it is seen in asbestosis or person who smokes. So let's look at the first type, which is a pulmonary anthracosis. It is the most innocuous or the non-injurious coal workers pneumoconiosis. It is usually asymptomatic and it is common in urban dwellers or smokers. They contain carbon pigment in the lung, lymphatics, and the lymph nodes. The autopsy will show linear streaks and aggregates in the pulmonary lymphatics. Alveolar macrophages with anthracotic pigment are called as dust cells. The second type is simple coal workers pneumoconiosis. It is characterized by two fibrotic opacities, which are the coal macules and the coal nodules. The coal macule is 1 to 2 millimeter in size, carbon laden macrophages. Coal nodules are larger than the macule and contain delicate collagen fibers. They usually involve the upper lobes, upper zones of lower lobes are heavily involved. These are located adjacent to the respiratory bronchioles, and they can also cause centrilobular emphysema. The third and the last type is complicated coal workers pneumoconiosis, which is also known as progressive massive fibrosis, as I told you before. It occurs in the background of a simple coal workers pneumoconiosis and occurs over a period of long years. It is characterized by fibrotic opacities with or without necrotic centers and intensely large blackened scars, especially in the upper lobes. These can be larger than 2 centimeters and maybe up to 10 centimeters. As I have told you before, the most commonly the upper lobes will be involved, and the lower part of the upper lobe is heavily involved. Microscopy will show dense collagen pigment necrotic center with local ischemia. This is an example of cross section of the lung. As you can see, progressive massive fibrosis is seen in the whole lung, especially in the upper lobes. And this black pigment is the coal deposition of coal. You can also differentiate it here. Note the extension of the scar into the surrounding parenchyma and retraction of the adjacent pleura. The macroscopic histological picture, you can see there is massive fibrosis. There is massive fibrosis throughout the tissue, and this black area is the deposition of coal pigment, and it is seen in the late stage or the complicated coal worker pneumoconiosis, which is also known as the black lung disease. Kaplan syndrome. This is the thing I talked about early in the list of organic dusts. Basically, Kaplan syndrome is rheumatoid pneumoconiosis. It is the development of rheumatoid arthritis in co-workers pneumoconiosis, silicosis, and asbestosis. So this is a thing which is common to all the three pneumoconiosis diseases. The morphology will show round from nodules with central necrosis, cavitational calcification, and microscopy will show central zone of dust-laden fibrinoid necrosis enclosed by palisading fibroblast and mononuclear cells. So this is all about the co-workers pneumoconiosis. The second example of pneumoconiosis, which is silicosis, and it is the most important one for you guys. It is also known as the knife grinder's lungs because it is commonly seen in people who sharpen the knives or other sharp-edged tools. It occurs due to the chronic inhalation of silicon dioxide or the quartz, and it is the most common occupational disease in the world and presents after decades of exposure to the silica. It is divided into two forms, crystalline or amorphous, but the former or the crystalline form, which is known as quartz or silicon dioxide, is more fibrogenic and is more implicated in silicosis. It is a slowly progressive nodular fibrosing type of pneumoconiosis. It is divided into acute silicosis and chronic silicosis. Acute silicosis occurs over a period of few days to few months, and chronic silicosis occurs after exposure for many years. Let's look at the occupations involving the silicosis. These are the miners, exposure to pencil, or people working in the lead pencil factory, quarry workers, slate tunnelers, agate grinding, sandblasters, grinders, ceramic workers, foundry workers, silica abrasive manufacturers. So these are some of the examples of occupations involving exposure to the silica. This is a sandstone which is used in polishing different metals. As I've told you before, it has two forms, crystalline form and the amorphous form. The crystalline forms includes quartz, cristobalite, tridymite, these are fibrogenic, and the amorphous form includes talc, vermiculite, mica, which is less fibrogenic. So these are the most dangerous ones. Let's talk about the pathogenesis of silicosis. Silica particles deposit in the lungs and are cytolytic to alveolar macrophages. These particles then activate and cause the release of mediators by the viable macrophages. The mediators involve interleukin 1, tumor necrosis factor, fibronectin, lipid mediators, oxygen-derived free radicals, and fibrogenic cytokines. These are also mixed with other minerals, but quartz has less fibrogenic effect, for example, hematite. Silica decreases cell-mediated immunity because macrophages fail to kill the phagocytosed agents. Talking about the gross pathology, the gross silicotic lung is studded with well circumscribed hard fibrotic nodules ranging from 1 to 5 mm in diameter, and they are scattered throughout the lung. There is also simultaneous deposition of coal dust with the calcification, and also the pleura is thickened and adherent to the chest walls, and similar nodules in lymph node and pleura as the nodules which were seen in the coal workers pneumoconiosis. The X-ray will show nodular lesions, which are the axial shadows, and the X-ray will also show necrosis and cavitation. This is normally complicated by TB or rheumatoid pneumoconiosis due to other occupations such as coal workers or asbestosis. This is an example of a chest X-ray of a person with silicosis. As you can see, there are various nodules, and also fibrosis can be seen. Fibrosis can be seen on both sides of the lungs, but it is most commonly seen in the middle and the lower lobe. The fibrosis in this kind of occupational lung disease is known as the eggshell calcification, and this thing is very important in regards to the silicosis. As you can see that this circle represents the eggshell, and it is hollow from the inside, just as shown here. That's why it is known as the eggshell calcification. This egg-like calcification. So let's look at the morphology of the silicosis. This is the gross specimen of a silicosed lung. You can see the scarring has contracted the upper lobe, and there is also deposition of silica, and also note the dense pleural thickening and massive fibrosis in the whole cross section. The microscopy will show nodular lesions which are concentric layer of hyalinized collagen surrounded by dense capsule of more dense collagen. Polarizing microscopy will show birefringent silica particles. So these are both the example of morphologies. Looking at the histological picture, you can see massive fibrosis here and there, and also deposition of silica particles. And this is a fine example of the nodule as shown in the silicosis. And in this nodule, you can see massive fibrosis. Looking at the clinical features of silicosis, it is usually asymptomatic in the early stages, and the routine chest X-ray will not show any kind of abnormality or disease. But in the later stages or with time, the X-ray may show fine nodularity in the upper zones. The pulmonary function tests are usually normal, but they may be mildly affected in the late stage. It does not kill a person immediately as it is a chronic disease, but impaired pulmonary function test severely limits the activity of that person and his daily routine. It also causes a decrease in the cell-mediated immunity, which increases the susceptibility to tuberculosis. One thing you have to consider is that crystalline silica is also a source of carcinogen, so the risk of lung carcinoma is also increased in chronic silicosis. So this is all about today's lectures of lung diseases. In the next lecture, we will talk about asbestos-related diseases and a very important autoimmune disease which is known as sarcoidosis. Thank you and have a nice day.